All right. Good morning, everyone. Welcome to Pediatric Grand Rounds. Thank you for joining us. Today's presenter will be Dr. Greg Robinson, PhD. He's a licensed clinical psychologist and has worked with the Child Development Clinic here at Carilion since 2005. Dr. Robinson trained at the University of Georgia, counseling and psychology, completed his residency at Lewis Gale locally. He has been an outstanding clinical collaborator and an active participant in all educational activities here at Carilion and multiple presentations locally. Please join me in welcoming Dr. Greg Robinson to educate us on pediatric OCD.
All right. Well, thanks, y'all. I've got a ton of slides, so I'll do as much as I can, get through it here. Disclosure statements, nothing financial or non-financial. So, all right, OCD. In 2013, they changed the DSM-5. OCD used to be under the anxiety disorder categories, but in 2013, they decided to give OCD its own category. And I think part of that is because there is anxiety that's associated, but there's also the intrusive thoughts, and they really thought that it kind of needed its own category. As you can see, there are tons of disorders. The ones at the bottom, I don't ever really see diagnosed too much, but of course there's OCD, and I'm going to go through these in the talk. There's body dysmorphic disorder, hoarding disorder, trichotillomania, excoriation disorder, which is a skin picking disorder, substance medication-induced OCD. I think probably the stimulants are most likely to do that, and then these other unspecified disorders. So what is it? So, you've got obsessions and compulsions. And obsessions, a lot of times OCD, we sort of kind of get a bad rap. I mean, there's people think, oh, I'm obsessed, and then there's this as good as it gets, and you have a guy that's got OCPD and an anger issue. I mean, and they do sort of the classic with the little forks and lining it up. But anyway, obsessions are really not pleasant. They're intrusive thoughts that pop into your head that you don't want to have. They're very unpleasant. They cause stress and anxiety. And most everybody has had these. They actually, Stanley Rockman in 1978 did a study where he took people with OCD, he listed the obsessions that they have, and then he administered a test to normals, whatever normal is, but people who don't clearly meet the criteria for OCD. And everybody has obsessive thoughts. The key trick here, the key difference is when you have OCD, your brain flags it as really as something that's serious. You have to deal with it, and you can't get rid. It causes explosive anxiety, and so naturally you have a desire to make it go away, and that's where the compulsions come in. Freud initially called it undoing, and that's kind of accurate, although the treatment, the psychodynamics way off with this disorder. But it is kind of like a psychological undoing. You do repetitive actions, overt or covert, where you feel like you have to make the anxiety go away. And I'll talk about those. General stats, 1 in 200 kids have it. Worldwide, approximately 1 in 100. Over half the adults with OCD said their symptoms start before age 18. It does have a profound impact on education across all levels, particularly when it has an early age of onset. This last one, second to last one, 14 to 17 years before you seek treatment. And that's because as we go through some of these, OCD, it's just awful. It gives you some of the cruelest thoughts you can ever imagine. The most politically incorrect, the most blasphemous kind of thoughts. Whatever you value the most is where it's going to get you. And so the thoughts are painful, embarrassing, and so people don't want to talk about it. It's the last thing you want to do. This last one's interesting. I actually didn't realize that till I updated this, that 40% actually have remission by adulthood, so that's cool. But I sort of mentioned this earlier. Their thoughts, images, impulses, you can't control them, super disturbing. Most adults realize that these are not rational. That's kind of what differentiates. There's a slide later here. And occasionally I have a kid now that I'm struggling with. Is it an obsession, or is it kind of a delusional quality with paranoia mixed in? But anyway, kids have some degree of lack of insight, but most people realize, okay, this is just my brain kicking out this garbage, and it's not really real. Accompanied by intense feelings of fear, disgust, doubt. You have a feeling that things are just not right. That's a nice way to put it. When you have this disorder, you often, when you're having a flare, things just don't feel right. It's like that just right feeling where everybody seems okay, that the world's okay and things are all right. Of course, now we all normals probably kind of know it a little bit more with this COVID-19, but there's just always feeling that something's not right. Time-consuming getaway in life. Technically, you have to have the symptoms for an hour a day to meet the criteria. And this is what I was referring to about the obsess versus OCD. God, these slides are so goofy. Most people looking at this probably don't even know the upper right. I was actually scheduled to see her last weekend, Liz Fair. I mean, that, being obsessed is not really the big difference there. We all get on jags where we like something. When you meet a new person, when I get a new bicycle, when you, gosh, all sorts of stuff. You get a new computer, what have you. You can you can enjoy something, new music. With songs, you might really get into a certain song and you listen to it over and over. Now, there is a form of OCD where sometimes you want the song to go away. And literally, it might be in the person's head for 10 hours a day and they want it to go away. But the key difference is when you're quote unquote obsessed, what society most people talk about, it's where you enjoy it. When you have OCD, it's not fun, no pleasure, and you feel pretty awful. All right, so some of the obsessions, that's what I'm going to go through now. This is what it's most known for, and I see it quite a bit, but what's fascinating about this disorder is it has so many different variants. The process is the same regardless of the actual content, but the content can vary dramatically. I mean, you can have some people who have contamination obsessions and the room is completely neat and they have symmetry added to it and they have to have it lined up a certain way. And then you have some people where the room's an absolute mess, but yet they're still worried about being contaminated. I've seen this before: urine, feces, germs like HIV, HPV, and I will have later slides where, with COVID-19, it's kind of thrown a wrench. And people who are dealing with their OCD well, actually can cope pretty well with this because they've kind of been worried about it all their life. So let's see. Household cleaners. Actually had a kid that was the thing. Kind of ironically enough, they're afraid to touch the bottle of the cleaner because the cleaner itself might contaminate you or get you sick. This is where, and I don't see this as much with kids because I only treat kids, but you definitely, adults get it. And trying to think if I've ever had a kid have this exact variant. I don't think so, but it happens. This third one, I wish they called it sexual orientation OCD. It doesn't sound politically correct now. What that is where what is it? Trying to remember the terminology. Basically, you like, if you're a boy, you like girls, or girls, you like boys. If you're, I guess you start wondering, if you're a boy, do I really like girls? Or, that guy was kind of cute. And then you start questioning your sexual orientation. And it can happen the other way around. If you're straight, you might think, gosh, do I like that other person? And you can start, then what happens? You get the groinal response because you're worried about it. And then that just fuels it. And then so they often do a lot of research and there's a lot of questioning that goes on there. But this is where it can be so cruel. Other examples, something like this will happen with newborns and a mom. They might be changing the diaper and they'll have a sexual obsession with incest or raping or hurting or inserting the child. I know, I'm sorry, I'm being a little graphic, but this is how this disorder works. And I'm just trying to give you a sense. So if you're working with kids or adults and they start talking about this stuff, and this is hard, and this is why people won't talk about it, because they'll think, oh, well, I'm a pervert or something like that, when, it's really this disorder. So it can be tricky. And if a therapist doesn't really know what they're doing, there can be bad consequences. Losing control. I like that picture. I got it somewhere where it's like jumping off the cliff. I think a lot of normals have had this, like maybe jumping off of a high place or pushing somebody off. Pushing somebody in front of a train would be one. Fear of, sometimes they're violent and horrific images that enter your mind. Stabbing your partner, for example, cutting their throat and visioning blood come out. That's why another reason why people won't talk about it, because they'll think, oh my gosh, this person's going to think I'm a nut and a sociopath. And they might even look up sociopathy for months because they're afraid that's what it is. But the key difference there, once again, is if you are a sociopath, those kind of thoughts are not scary to you. They're egocentric and you enjoy them. Religious obsessions, I've seen this quite a bit. It's where you worry about offending God, blasphemy. You worry that you've committed a sin. And so there's this excessive concern about right and wrong. And of course, the compulsions, typically prayer. Harm, I kind of touched on this already. This would be, you're afraid that you're going to stab somebody else. This is one I worked with the kid one time, an adolescent who was driving, and the image would come that she had this image that she was going to turn the car into the opposite lane and get in a wreck and kill somebody. So we actually did some imaginal exposures. We'll get to the treatment later, where that's kind of what she did. So we try to get her to habituate to those kind of thoughts. Fear of blurting out obscenities, like say you're in a religious sanctuary or something and you might say something sacrilegious. Fear of stealing things, stabbing the dog, watching it bleed. Obsessions related to perfectionism, and this is where it's different than like the OCPD, which I have a slide on that. They enjoy making list order. With this, it's really, I worked a long time ago when I used to work with some adults, and she would line up the pillows in the office. So that was one of the exposures, was to knock them kind of off kilter, and boy, that's hard. And I've had this certainly in my office plenty of times. I usually might purposely change my diplomas and make them tilted in the room. But they want things to be neat and in order. Also, that goes along with that is like forgetting things, inability to throw things away, although that's a little bit, that gets into hoarding, which really is its own disorder. Typically, usually there's grief and loss and trauma associated with that. Other obsessions would be like fear of getting a physical illness or a disease. That's pretty common. Superstitious ideas about lucky and unlucky numbers. Like, for example, you might think 6 is a bad number because if you do 666, that equals the devil, and maybe 7's a good number, or 23 is a good number because of Michael Jordan, of course. But anyway, and that's kind of interesting too, not to get off on that, but athletes often do have some kind of superstition. I mean, Jordan would always wear a UNC jersey underneath his, or some kind of T-shirt, I think, underneath his jerseys, or at least he had it in the locker room. I know maybe he had underwear or something, but anyway, I'm rambling. Let's see, compulsions. Maybe I'm going a little bit too fast. I don't know. We're rolling. The compulsions, the classic is the cleaner, where they're afraid of catching AIDS from a toilet, or maybe HPV or something. And so, of course, the desire is to wash your hands. Fear of getting sick from touching hand sanitizer. Let's see here. Oh, perfect. Fear that the tape has trapped contaminants. Washing hands for 5 minutes after a handshake. Showers typically, sometimes they literally take an hour because they have to be perfect. And you can blend these things too, like with that lucky and unlucky numbers. Like, for example, you might have to scrub your hair 10 times in the back, 10 times in the middle, 10 times in the top. You have to get your pits 15 times, or maybe it needs to be 7 because that's your lucky number. It all depends, but it can sometimes take that long. Cleaning your backpack with Lysol, that would be an example. Have chapped hands. I'm just kind of throwing out examples of stuff I've seen over the years too. Let's see here. Checking. This would be check that you don't harm other people. Or like the stove, leaving the stove on, leaving the skillet on, leaving the eye on. Checking that you won't harm yourself. Checking that nothing's terrible happened. Now there's a good example that it's called hit and run OCD. And I got to meet this guy at one of the international OCD conferences. Jeff Bell used to be one of the national spokespersons, and he had hit and run OCD. Poor thing, it's so bad. So you're driving in the car, and what happens is you feel kind of like you feel a bump in the road, and so your brain, it kicks in the OCD. Oh my God, what if I ran into somebody? Oh my gosh, sorry. What if I ran into somebody and oh my gosh, what if I killed them and they might be dead? And then you keep driving, and then the obsession might even hit you a little bit later. And so what this guy would do is, he would circle around. I mean, he wouldn't even sleep sometimes. He would go to emergency rooms and he would visit. He would call the police stations to ask if there were wrecks, and if somebody had been hit. And it was really awful for him. They got good treatment, and he's doing extremely well. He has a lovely baritone speaking voice. So that's kind of an example. It's a little bit of an extreme example. Probably the most common is checking the doorknobs and the locks. That's probably the most common. Repeater, router. That's so funny. I put a router down there. I forgot I did that. And if this is something I've seen before, where like one of the kids I worked with, when they got in the car, they had to have a certain routine with how they got in the car. I think I changed it around for confidentiality, but something like an example would be like maybe they have to turn around 15 times. This is probably a bit exaggerated, but touch the seat 5 times to make it right. I mean, they might have lots of different rituals for how to sit down in the car properly to make sure and it's once again, you get that temporary just right feeling. It's because if you don't do these things, you have this extreme anxiety and you think something terrible is going to happen. And usually it's tied to a thought like, oh my gosh, if I don't do this, we're going to get in a wreck and dad's going to die and it's going to be my fault. I mean, that's how painful these things are. Walking up and down steps. Yeah, that could be one. And, going through a door and turning around 2 times or something like that. I've seen that. Oh, and the reading, this can happen. And I've had it with writing. Not too long ago, I had a kid that was real perfectionistic with the way he wrote, and if the letters weren't formed, I guess that's really probably more symmetry, but it's a little bit repeating, because if he was doing well and he got it wrong, then he'd have to restart from the beginning. And of course, we worked on exposure, and we used a timer, and we used positive reinforcements, and he was doing fine by the end. But like an example, a word might feel bad, and so they might have to start back at the beginning of the page until it feels right. Let's see here. All right, come on, Dookie. All right, good deal. Mental compulsions. These are what you say to yourself. Like it's typically like a prayer, but it doesn't have to be a prayer. It can really be rumination. Like when I talked about the sexual orientation OCD, where you might really ruminate and over, and you might analyze all the interactions that you had that day, or maybe even years ago, when you're interacting with a certain person and you liked them and you wondered, oh gosh, does that mean I really wanted to have sex with them? And you can just review these things over and over. And that's where there's a form, and when you do the research, it's called pure OCD, which is kind of a misnomer, because you don't really, it's called pure O, and you don't really just have pure O. I think he coined the term. It's really Stephen Phillipson who did it. He's a therapist in New York. But it's where you basically don't see the compulsions, unlike these other things like checking and routing and doing all these other things. You don't really see them, and it's a little bit harder to treat. In the beginning, people were pretty baffled with how to treat it. So yeah, counting to a task to get a good number. Replacing a bad word with a good word to cancel it out. I mean, there are all sorts of things, but it's really, it's often prayer, rumination are probably the main things that you see there. Other compulsions, oh boy, this one's probably the most common that I see with kids, is asking for reassurance. The kids, and once again, because you have that sense of uncertainty, the just right feeling's not there. You have that doubt. The French call it the doubting disease. It's where you I just don't think anything's right. And so they'll be like, Mommy, is it okay? Mommy, is it okay? What I've seen a lot with kids too is, Mommy, it's like they worry if they're going to be loved. And there's no evidence that they haven't been loved. I mean, these are not kids that have necessarily been abused or neglected or anything like that. Their brain's like, does Mommy love me? I don't know if she really loves me. Does she really love me? Maybe she does, but then she was mean to me the other day. Mommy, do you love me? And so literally, I mean, I've had it where it's hundreds, literally, at least, maybe I think it's several hundred times a day, where they might ask the parent, do you love me? Do you love me? And then, so what happens, there's this concept called parental accommodation. And what the parents do, of course, is they say, well, yeah, of course I love you. Of course I love you. And unfortunately, they inadvertently reinforce the pattern. So a lot of times I'm working with the family. I mean, I always work with the family, because typically with kids, they pull the parents in for the compulsions. Avoidance is a huge one. I mean, it's kind of, with this, you often avoid things that trigger you, just like with all anxiety disorders, and then you can make your life really, really small. Scrupulosity type. Yeah, so we've kind of already talked about that. Those are the examples. Oh yeah, like having sex with the Virgin Mary when you're in church, and so you might have to say this over and over. I did have, a good boy thing. I had a boy that was afraid that he was not being nice to his brother, and that I don't know if you worried that he was going to go to hell. I mean, that's typically where you go with this, is that you're going to have some internal damnation. Actually, the guy that trained me, he's at, I believe it's at Temple. I mean, I wouldn't go this. I mean, his treatment, one time he would do like seances and stuff. Like he was acting like he was calling the devil up. He said one time the janitor was there and was like, what the heck is going on? Because I guess he was doing it at night. I'm not sure I could do that, but that's what he did. And I'm sure it probably worked. unless the person got completely flipped out. While I say that, I mean, that's a pretty hardcore exposure. You definitely don't start really hard in the beginning. You want to start at a lower level. Well, I'm getting the treatment, but anyway, you want to start at a lower level where the child or adult can handle it. But those are kind of the examples there. Oh boy, this one's hard. This one's really hard because relationships are hard. Um, and so, there's some normal elements to when you have a relationship. The question, really with this, there are two prongs. You've got the relationship part, and then you've got the partner part. It's normal when you get in a new relationship. Gosh, is this the right person for me? Is this the right one? Is this the perfect one? Is this the one? And so that's really kind of the relationship part where you really wonder, is this the right relationship? And then partner focused is when you focus on like their physical, and this is not something you want to do. That's what's hard. I mean, you start, you're having these intrusive thoughts, like maybe the person's nose looks crooked, or maybe they're losing too much of their hair, or they look like Jeff Foxworthy right now. No offense to Jeff Foxworthy, he's hilarious. But social qualities or personal attributes such as morality, are they smart enough? Do they have the same religious beliefs? Do they? And so people that have this, they take it to, like I said, typicals. I mean, some of this can be normal. That's where it's hard. But when you have OCD, and when your OCD attacks the relationship, which it often happens because once again, it attacks you, whatever's most important to you. I mean, it can just make you miserable. And it's literally, I mean, like most of the day, that's all the person can think about, and it's anxiety provoking. This is a really old slide. I just kind of kept it, I guess, because I like the way it lines up. It's kind of nice and neat. But it's kind of it kind of has the obsession on the left and the compulsion on the right. So anyway, I don't need to really go over it. All right, now there's a lot of spectrum disorders. This is what was added in 2013. There are a bunch of them. The first one that I'll talk about is body dysmorphic. I've seen it one time when I worked with adults way back when, and it's really hard. This one I feel like takes almost on that delusional quality where the person has a perceived defect in their appearance. I mean, with this person, it was really hard. And I think, I guess probably a decent example may be Michael Jackson, I think, with some of the stuff he did to his body. I don't know. Of course, he had all sorts of other things, I'm sure, too. But it's where you're preoccupied with an imagined effect. I know he had tons of plastic surgery. That's why I use him as an example. Maybe he's not the best one. Maybe that comedian that passed away not too long ago, maybe she had it. But it's where you have this slight defect in your appearance, or you think you have a defect. And oftentimes, typical people don't even know what they're talking about. They don't see it. And they'll check it. They'll look in the mirror constantly. And it's not really a narcissistic thing. It's actually stress induced, and they often seek out cosmetic surgery, and then they go on, and then they get more and more. And then sometimes they do start to have unusual appearances. Trichotillomania, and this is where it's different because it's really almost more like a tic. You have this urge, and it's really you have this urge to kind of pull it out. You typically use the habit reversal and probably the alpha adrenergics with that. But it's a different kind of thing than pure OCD. Hoarding disorder, I kind of referenced that earlier. It's where you can't discard of things or possessions. I watched a show one time about it, and it's really rough. And what they actually have people that they hire that I forget what they call them, but they basically go in and they help slowly declutter the houses. You literally go into the house. It's similar, though, in that you arrange, order, and collect things. I think a lot of it is when there's some grief and loss, too, and they don't want to get rid of stuff that seems to have meaning to them, even though when it may just be like the box to a Connect 4 or something like that, and you don't even have the game anymore. I mean, it would be something like that. It's not quite as responsive to ERP. Okay, yeah, excoriation disorder. This is skin picking. You repeatedly pick at your skin to remove small irregularities such as moles or freckles. And you can actually hurt yourself if you do it too much, obviously. All right, comorbid conditions. This is really important. There are a ton with OCD. Tic disorders, up to 30% of people with OCD have a lifetime tic disorder. I think, and I can't see who's in the audience, and I don't know if there's a neurologist in there, but I believe, the caudate is one major area that's been implicated with OCD, and it's kind of the automatic transmission in our brain, where typicals can just kick that thought away, Whereas people with OCD, they just, they glog onto it and they can't let it go. I think the putamen is next to it, and I think that's implicated with kind of some of the tics and the movement. So 35 to 50% of the people with Tourette's have OCD. So there's a high correlation, but of course, only 5 to 7% of people with OCD have Tourette's. But tics are something to look for. Depression, of course, it makes sense. I've talked about these thoughts that you have, and you don't want to have them, and they're miserable. So it makes sense that it could make you depressed. That's 41%. Almost seems kind of low, frankly. 50% have suicidal thoughts. And then this one is pretty unnerving, that 25% of people with OCD, now this is pulled really from the DSM, so it's looking more at adults, have had a suicide attempt. Because, you get it, I think. 76% will have a comorbid anxiety disorder. That would be like maybe a panic disorder, a blood injection injury disorder, something like that, like a phobia. Because your system's often ramped up when you're having OCD. So I think you're more likely to have anxiety. And then this OCPD, I'll have a slide on that, but there's still a lot of comorbidity. Substance abuse, 30% will have a substance abuse disorder at some point in their lives. And I think it's typically, it's self-medication, because you might temporarily feel better. It might blot it out for a minute, and you might kind of get taken to a different place. But then what happens, of course, is then you got a whole nother set of problems that you have added to that, because then you start getting an addiction with that. With the tics, by the way, they both have these repetitive behaviors, but tics don't have the obsessions before it. You really have this sense of discomfort, this urge. It's really an urge. I think I already mentioned that. With those, you use the alpha adrenergics and different habit reversal training. Now, similar addictions. Now, of course, we just mentioned 20%, I think it said, of people with OCD have or 30% have a comorbid substance abuse disorder at some point. The difference there, though, is the initial part with the addictions is you get these good feelings, and it's something you enjoy doing in the beginning. Whereas OCD, the behavior is never really ever pleasant. You're always doing it to escape. Although I guess you could argue with substance abuse, you're escaping anyway. So I might be rambling a little bit, but there's some similarities here, but there are distinct differences too. Autism, that's where I spend most of my time. This is the world I'm in most of the time. And it's not uncommon to get intakes and people say it's OCD when really they're having stereotype behaviors, or they're having their fixations on topic, and the fundamental difference there is those kids love it. I mean, they love talking about Minecraft, or, oh my goodness, the Titanic, or Ford F-150s, or Civil War battles, or what have you, the things that we all hear sometimes. And it's pleasurable. I enjoy doing it, and it's not scary. People with and of course with OCD, you might have problems with relationships, but you don't have the category A symptoms of the nonverbal communication, your inability to have a reciprocal social communication, the conversation, those kind of things. You don't have that when you have OCD. Now, this is the OCPD. They both have list and perfectionism. People with OCPD typically don't seek out treatment. The only time I think they typically do is if their spouse is ready to divorce them or kick them out or break with them, or their partner or what have you, because it can be difficult. You're really rigid. You have to have things a certain way. It's correlated with some it's extreme perfectionism. And they don't really mind it typically. The only time I think it becomes a problem is if their partner gets tired of, because it's hard to live with. Psychotic disorders, they both can have strange and bizarre thoughts. The main thing is the psychotic disorders have the delusions, and that's what's so interesting, because when you have there is a specifier with OCD. It's called with limited insight, I believe is what it's called. And that's where, and I had a person once who actually had autism that also had this, but literally they thought it was totally fine to have chapped hands and to wash their hands all the time. They did not think it was irrational or there was nothing wrong with it at all. They thought it was made perfect sense and it was fine. But typically people with OCD have good reality testing and realize that these intrusive thoughts are intrusive thoughts. And this is the Yale Brown. This is one of the instruments that I figure I'd throw this in there. I really just there's a symptom checklist, and then there's a severity scale. I probably should use the severity scale more, but I really use the symptom checklist mostly in the diagnostic assessment. And it's got, a long checklist that lists all the obsessions and compulsions, even more detailed than what I went over today. This is really an overview. But then there's also a severity scale. This is what's used in the research studies. It's 10 items, each item 0 to 4. And then, you get this number, and it's pretty handy because then you do the intervention and you've got this one metric there. It's been around for a long time. No, and this is the children's version, 2007. Causes of OCD. This is from an old book, but it's still accurate, where you have the obsessions, you got the anxiety, you engage in the compulsive behavior, and you feel temporary relief. Okay, now I'm not going to go over it too much, but the main area, from my understanding, is that basal ganglia, but there's also activity in that frontal cortex. I mean, this is one disorder. I really probably should get a slide. I imagine there's one out there, and the next one actually shows it a little bit, but they have mapped the pathway with OCD. This is one of those disorders. It's clearly, it's genetically determined in a lot of cases, and it's clearly a brain problem. It's not due to, this. In the beginning, they did a lot of psychodynamics, and where you try to what does that mean that you think you want to stab your child? Oh my gosh, that's the worst thing you can do for a person with OCD, because that will just fuel it, So anyway, but the basal ganglia is impaired, and the frontal cortex. I think those are the main areas that are impaired with OCD. This is from Jeffrey Schwartz. Actually talked about his 4 steps the other day. They're generally pretty good. He's at UCLA. This is an old book, but he used, I think these are SPECT scans, I think is what he used, where it looks at glucose metabolism. And, you can see that frontal cortex and prefrontal cortex just goes nuts because you're constantly thinking and you're trying to solve the problem. One example I use with people is I think this is kind of the feeling you get. So say you have a loved one that's flying to France, and you hear on the radio, or if anybody listens to the radio or what have you, you hear, oh gosh, there's been an awful plane crash and most of the people on the plane have died. And you don't know if that's the plane that your mom or loved one was on or not. I mean, that's kind of how intense it can feel, even though it seems to maybe somebody else is kind of silly that, oh gosh, all you did was touch a table and you think that you have HIV or something, But anyway, those are the areas and when he did his 4 steps, which are relabeling, reattributing, refocusing, and then revaluing, which is almost kind of the outcome of the first 3. He found that there was less metabolic activity in those areas that are lit up right in this picture. Causes, of course, we think serotonin's one of the major thing. Anafranil was used in the 60s. I learned about it first when I read Judith Rappaport's The Boy Who Couldn't Start Washing. It was so cool. I actually got to meet her 2 years ago at the OCD conference when it was in DC. That's pretty awesome. I mean, we didn't have any super meaningful conversation, but I was she really was she wrote the first really mainstream book. I read it back in, I think, right after college, The Boy Who Couldn't Stop Washing. It has a lot of vignettes. I still have it in my bookshelf. Let's see. So chronic administration of clomipramine and SSRIs results in increased serotonin in the orbitofrontal cortex, and it's correlated with decreased symptomatology. PANDAS is another cause of OCD. I've maybe seen it at time. I do think it probably exists. But the difference here is you get this dramatic. It's not like it kind of builds. Sometimes OCD is kind of more a slow, kind of insidious onset, whereas this is like dramatic onset where it just hits you, and you're doing all these things, and it's preceded by a strep infection. They also had these other little things that can be correlated with it, like some separation anxiety, even some disordered eating, urinary frequencies, sensory issues, like you might see with the ASD, sensitivity to clothes, sounds, light. And what they think is that the antibodies attack those basal ganglia structures. And so they treat it with, I guess I'm not sure how to pronounce it, immunoglobulin. Sorry, I can't say that too well. And I think they use antibiotics as well. And so that typically helps. I think sometimes the people still have, particularly if there's a predisposition, they may still have some OCD afterwards. Genetics, that's the concordance rate for monozygotic twins, 0.57, so pretty significant. Dizygotic, 0.22. All right, so sweet. We'll go to treatments. Medications. I've updated all these slides since this is really more of a medical audience here. So the 4 that have been approved by the FDA are the nafranil, fluoxetine, fluvoxamine, sertraline. They've done studies on these different drugs, and they all work. None really seem to be better than others. Of course, the side effect profile is different. Clomipramine was the very first one. It's kind of a dirty drug, of course, because it's the tricyclic. It hits all these other things like norepinephrine, histamine, acetylcholine, dopamine. Much worse side effects, but occasionally people have to use it if they're non-responders to SSRIs and they're treatment intractable. Let's see. While 4 are approved, there are 7, but 4 are approved. And so I looked up, and these target. I got this from the IOCF. They're high. I mean, these are the target, and it is for kids. When I looked this up, that's what it said, at least there. You want to shoot for the higher. With OCD, it takes more, I guess, than it does for depression. You know, like for fluvoxamine, up to 300, I think, is the max. Now, there is a CR version available, apparently. Sertraline, 50 to 100, I guess. Fluoxetine, you start at 20, go up to 80. Comes in a liquid form, which is pretty cool. Paxil, I don't know if people use Paxil that much. Honestly, I think it has a shorter half-life. I think you get more of that discontinuation syndrome. I don't hardly ever see that used anymore. I honestly can't remember the last time I saw it. Celexa or Lexapro, you know, they've not been systematically studied in children, but they probably, I imagine they were. This slide, you know, it's an old slide. Oh, it is copyrighted, but it's, you know, the gist of it here is that, you know, you've got this presynaptic membrane there, and, you know, you're squirting that serotonin out, and then it goes across. It's in the synapse, and you've got the postsynaptic. But, you know, I think what happens is the 5-HT stops that the reuptake transporter, so that more of the substance floats around in the synaptic cleft. And, you know, and I guess probably the withdrawal, I imagine you get the discontinuation because probably you start releasing less of it on the back end. I mean, on the front end, from the nerve terminal, probably. Okay, side effects. You know, with clomipramine, you can get anticholinergic, dizziness, sexual weight gain, tremor. SSRIs, insomnia, GI issues, sexual side effects. You guys know all this stuff. GI upset, it says. I don't know about that. Rash or headache. I don't know that people do any of those lab results. I just pulled that from the IOCDF and figured I should put it in there. Medications best. You know, that's a good question. When do you use drugs? You know, if it's mild to moderate OCD, we usually try the exposure and response prevention. If it's moderate to severe, you want to do both. And I've got some research slides here at the end. Let's see here. Brain surgery. You know, I can't see my content underneath, but there are, I believe it's like a capsulotomy, I think is what it is, and cingulotomy. It's a cingulate where they go in and they ablate part of the cingulate gyrus, and I can't see the other part underneath. There's another one. I think it's called an anterior capsulotomy, I think is what it's called. I mean, you don't do this unless obviously it's, oh, there it is, cingulotomy right up there, yeah. You don't do this unless it's really treatment intractable, but they have had success with it. Deep brain stimulation, that's when they actually put electrodes in there. Yeah, they put it in the anterior capsule, ventral striatum. 61.5% of the 26 patients were responders. So it does help. There is a fella, oh gosh, this is too busy a slide. But if you're tired of hearing my voice, I figured you could read all this stuff while I'm talking. But there is, I'm trying to remember his name. He came through this clinic, and I saw him do a talk. But there is one fellow in Roanoke, sorry, I'm drawing a blank on his name, but he does do transmagnetic stimulation. I think the magnets he have are the more shallow ones, the one that don't go quite as far. But there are 3 major targeted areas for OCD. I mean, he uses it a lot for depression primarily. I think more research supports that, but there's some support for OCD with the dorsolateral prefrontal cortex. Bottom line, while it may not be the most promising target, it still has it may be the problem. I think it should not be a not. Anyway, this area is one area where they've looked at the orbital frontal cortex, which of course makes sense. That was that slide where it showed it lit up with the glucose. They've done 3 studies looking at it, found positive results, but they only lasted a month. The last one is, what is it? The pre-supplementary motor area. Studies have shown the best outcomes here, I guess. This area of the brain has been observed to be consistently overactive in patients with OCD. General reduction in OCD symptoms, improvement in functioning, as well as depression and anxiety. They held for at least 3 months, so that's pretty cool. Second study found decreases in OCD symptoms in addition to depression and anxiety, and again, 3 months later, benefits were present. So, there's probably something to it. I don't know. I think you have to fail a lot of the drug trials first before you can do that. Oh gosh, this is such a silly slide, but this is our psychological treatment. It's exposure and response prevention. It's the only thing that's really been proven, although ACT, I've got a slide at the end, they're looking at that. You list situations, the things that make you nervous, you rank them from highest to lowest, and you expose the kid to them. The theory of it's, Foa, gosh, it's back in the 80s is when this stuff started. Obsessions are a threat-related memory or perception of an event, even though the threat's not present. Mechanism of therapy is to evoke the fear, decrease the fear response through time and exposure, and you get habituation at the end. It's difficult. This therapy, it's really, and I don't think all therapists probably can do it, because really most of the time when somebody comes in, you kind of want to be, you want to make them feel better when they're in your office. The problem with this is you actually make them worse in the beginning. I mean, they're not worse, but they feel awful. I mean, you are triggering them on purpose. And so it's hard. You have to be able to watch that anxiety. I should have a slide where it has the anxiety curve, but most of y'all know it. You get a spike at the top, and then over time, you start to habituate and it goes down. And so you actually purposely provoke the child. This is Marty Franklin, who's the guy that trained me back in 2008 when I went to one of the trainings. His daughter said this: blah, 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 do the thing you're afraid of, blah, blah, blah. The more you do it, the easier it gets. I mean, that's really the gist of it. It's not really hard to understand the theory. The idea is not hard, but the implementation, it does require creativity. It really does. You have to be creative, and you have to really involve the parents. March, he's down at Duke. He's written a couple books. These are kind of the things he talks about: psychoeducation, feelings thermometer, mapping OCD, and exposure. This is stuff I talk about a lot. Externalizing OCD, where you want to boss it back, describe it as, you want to externalize it. And that kind of relates to that Jeffrey Schwartz, where you relabel OCD. That's really where this is coming from, where you try to say, okay, this is not me, this is my OCD. Actually, the International OCD Foundation just sent this nice little card for, uncertain times, and it talks about, one of the things is, ask yourself, is this me or my OCD? So externalize, and having the kids come up with fun names can be pretty cool. Mapping it is where you basically map their experience. You figure out when it happens, where are the triggers. You start with easy, go to hard. Now with these, March did it where he puts the hardest at the top and the easiest at the bottom. When I'm actually working with kids, I don't know, maybe it's me, but I like the easiest at the top and the hardest at the bottom. It doesn't really matter. But this gives you a sense of it, with the least fear person maybe touching a waistband with rubber gloves on, to the last one going to the toilet in public places, like touching doorknobs, and this is where you have to be creative. You have to figure out, you basically talk to the kid and you figure out what is it that's least stressful, but still a little bit stressful. And then you go up to, obviously the hardest thing would be using bare hands. And I've done this in the office. Sometimes you'll have, like, one of them's a good one, is to have like the father or the parent open the door and then you touch their hand, something like that. Or like step 5, have the parent grab the doorknob and put your hand over hers. You just have to be sort of creative and figure out, what can the kid tolerate. This with counting is a little bit harder. Like, say 7 is, or you have a certain 7 is bad, right, and 4 is good. So that's kind of ultimately you want to get to know counting, but you kind of do these little tasks here. Like if 4 is your good number, you want to try to do it 3 times instead of just doing it 4 times. You want to change the nature of the ritual, and it'll create anxiety. But once again, over time, it should habituate. Yeah, petting a dog of an increased size. A lot of the times I use the example of jumping in a swimming pool when it's really cold. Think it's going to be chilly, and initially it's kind of a harsh reality when you jump in the pool, but after you swim around, you feel better. So I've got the gist of it. Cognitive therapy. Now, traditional cognitive therapy for anxiety will not work with OCD. If anything, it can actually make it worse, and that's where it can be tricky. This focuses more on the appraisals of the thoughts as opposed to doing like, what's the evidence that you want to stab your wife or something like that. That, man, you'll get yourself in trouble if you start going that way with a person with OCD. You'll just fuel it and make it worse. Individuals with OCD interpret things differently. You have an overestimation of harm. You have doubt possessions. It was Gail Steketee came up with this kind of theory. Perfectionism, guilt, responsibility, rigidity. I don't know if we can do questions. We'll go as much as we can here. Constructive self-talk. And this part where it is valid is what you say to yourself during the actual exposure. Although you don't want that to become a compulsion, because you can do that too. It's tricky. So this is a good slide. I think this is you want to break the rules. Like delay how long it is before you actually do the ritual. Delay the 1 hour would be too hard. But eventually maybe you could get to that. Shortening the ritual is real common with washing. That's what I typically do, or praying, or doing covert rituals. Do it a little bit differently. We already mentioned that with like the numbers, like maybe don't wash your fingers in order. Do it slowly instead of rushing to get it done and getting it done. You do it kind of slowly, and maybe you miss a finger. You want to cultivate detachment. That's what that relabeling, and you want it to be like, you realize, okay, this is really a stupid brain bully that's messing with me. That's what you want them to really do, and then eventually they can discard it and it doesn't bother you as much. That not me as OCD is good, but that can become compulsive at the same time. It's hard. That's what's tricky about treating this disorder. Oh, good. I'm ACT, and I probably could spend more time with it. I've been at some presentations. I sort of get it. I don't fully know exactly how it implements, but the bottom line, I think, with it is that it's kind of getting into the mindfulness type of stuff, and where you try to accept the thoughts, and that's what makes sense, because ultimately that's what you want to do. And I didn't really go over this, like with, let's say, the hit and run OCD I referenced earlier. I mean, when you get really good at it, this is what Jeff learned to do. He'd be like, you know what? I think I did hit somebody. Maybe I really busted, this is going to be graphic, everybody. Maybe I busted their head and their brains are all out on the highway and their guts are out there and the vultures are going to come eat it. And you make it almost outrageous, But with this, I think with this, you're just allowing those thoughts to be there without trying to attack them. I think it's a lot easier said than done. Contact with the present moment. I think in this part, this is good. I mean, you use this with panic, the grounding where you go through the senses, observing the self. Values, there's a lot of this stuff about values. It seems a little bit philosophical, but I think the general idea is good, and I think the practice of trying to allow yourself to accept it is what is really good. Okay, good. I got this in. Limit watching TV. One thing said 5 minutes, one said an hour. I would say no, 10 is probably more reasonable. You don't want it to get a hook, though. That's the hard part. Set a safety plan, disinfect surfaces 1 time a day, stick with it to the surfaces that are frequently touched and truly needed. Wash your hands with soap and water. This is the kind of stuff you normally would see. Be kind to yourself. Avoid the temptation to learn everything about it. Don't excessively wash your hands, as it leads to injuring your skin, making it less protective against infection. Don't let social distancing rob you of your support networks. I mean, this is kind of stuff you're all talking about. Use those things. Gosh, it's a busy slide, but I like it. It's try to be mindful about what you're feeling. Everybody's going through this to some extent. Stay calm, meditation, deep breathing. Limit the exposure to the news. Set up a routine. I mean, obviously, that's really important for all of us. The more routine you can get, the better. I'm coming into the office all the time. It's nice. I mean, it is a little bit riskier, I guess, but the routine is certainly nice. Reach out to support networks, FaceTime, Zoom, Discord. That's something my daughter uses. I don't really fully understand it, but it's some kind of online way to connect. Focus on things you can control. Reorganization, yard work. Yeah, you should see my backyard. Hobby, healthy habits. Exercise is super important. Drink water, healthy food. I mean, this is good hygiene for everybody. Right now, sleep schedule, go outside once a day, come up with a self-care toolkit for the senses, touch with the blanket, taste, sight, hearing, smell. Research, the guidelines at March, it's really exposure and response prevention, been supported in open trials. I'll kind of hit some of the big ones. Meta-analysis. Abramowitz is down at Chapel Hill. He's done a ton of research. Meta-analysis supports the efficacy of ERP. Superior is equivalent or even superior to medication. Most of the studies show it's even, and really a combination ultimately is what has the best results. If they do just medication, you see this relapse when you take them off. So like this was the original POTS team is in 2004. Marty Franklin was in on this. And so basically, this is using the children Y box, that number. So the lower numbers are better. And so as you can see, that square one has the best results down at the bottom. The circle, the open circle is placebo. Of course, everything, you get a little bit of placebo effect. And let's see, what is it? Cognitive behaviors, the dark circle, and it's actually a tiny bit better. That wasn't statistically significant, though, than the medication. So they both work, but that bottom one showed the best results when you combine them. POTS 2, and it's really an augmentation strategy. Wow, too busy a slide. But the bottom line is basically one approach was where psychiatry, basically just a psychiatrist did the medicine and kind of gave instructions on the core procedures, but didn't actually do the procedures with the patient. Whereas approach 2 has a psychologist doing the CBT protocol for 14 visits. And of course, when you do the full protocol, you got better results. I mean, that was the best thing. Yeah, that's the same graph, I think. Oh, they did. This is pretty cool. Yeah, they did a little POTS Junior. So this is pretty neat with little 5 to 8-year-olds. Yeah, the March from Duke, Franklin, Freeman, and Garcia have done a lot. I don't know the other names as much. But, they did an RCT of family-based CBT versus relaxation therapy. And, of course, they found that the family-based CBT was more superior on outcome. So that's pretty cool. Yeah. Group, they've done studies with group CBT. I don't really see that. I've never done that, but they did do a study back in 2004. And basically, pre-treatment, everybody's the same. Post-treatment, looks like the individual and the group were both better than the waitlist control. So it worked. Oh, there's also MAST. I had a student here back when I had Virginia Tech students. Gosh, it was 2009, I guess it was. And she was studying with Olendick down in Virginia Tech, and she was looking at MAST OCD exposures, like intensive. And, they have good outcomes with it. I mean, it's a lot harder, but you get it quicker. It's where literally you spend many hours a day doing the exposure. And so it works. Family accommodation, I mentioned that earlier, I believe, where I don't know why I threw the slide in there, but they have done research on it. It's kind of a current trend is looking at family accommodation. Family-based treatment, you really have to have the family involved. Yeah, and that's kind of I think that's a repetitive thing where compared with just plain relaxation. I mean, obviously the CBT turned out better. Oh, this is the slide. Yeah, so the CBT group obviously has lower is better in this one, better outcomes than just relaxation. Comorbidity, tics and POT data. Tics don't moderate for CBT. Externalizing behaviors, and when you have those and you have depression, you have poor treatment outcomes. Depressive disorder, poor outcomes. And these are some of the resources here. International OCD Foundation's just got a wealth of information. It really is quite helpful. And we're actually having the online, there's going to be an online conference. I forget, it was going to be on the West Coast this year, I want to say, I don't know. But anyway, it's on, they're going to have a conference online now, which is pretty cool. Some books that are helpful. Boy, I talked y'all's ear off. There's the March book. This one's kind of old. I should see if he has a new one, but it's a great book. I have that one. Some children books that are pretty helpful too. So how many kids in the U.S. have OCD? Well, the IOCDF says 1 in 200. The best psychological treatment, it is not rebirthing therapy. It's funny, when I went 2 years ago, that's what one of the guys signed my book and said something about that. But exposure and response prevention, of course. First line medication. Now sometimes they'll use the atypical antipsychotic, but not first line. I think that would be for the kids that have that difficulty with insight, where it takes on kind of that delusional quality.